Yeah, okay, great. So thanks so much for inviting me. My name is Brian Hogan. I'm one of the liver consultants at King's. The brief that I had from Andy Retter and from Pete was transfer of the liver patient. So I guess that's quite a wide brief, and I have in my mind the ones that are more challenging from my perspective. But what I thought I would do is go through a few slides, but I won't take up the whole session with me talking, and then there'll be maybe 15-20 minutes towards the end for some discussion, and I guess people might have some cases they wanted to talk about. So hopefully that's the format. I thought I'd start with sorry about the cough. So I was supposed to be on the unit today, so I should have been on liver ITU, but I've acquired COVID for first time in 2 years, and it finally got me. So I'm at home and coughing. Sorry. So this is just a small case to start with. Let me just see if that works. So there you go. So this is the kind of patient I think presents us with quite a significant challenge. Can you see the slides all right and everything, so you can hear me okay? Yeah, great. Yeah, so 17-year-old lady, she's got a hyperacute liver failure from a paracetamol intoxication. She's got a low BMI, and when the decision to transfer is made, she is not well. She's got a sinus tachycardia. She's vasoplegic with a NORAD requirement of just over a mic per kilo per minute. In the context of her intubation, she had a 6-minute asystolic arrest, and she's now got fixed dilated pupils. She's severely vasoplegic with a distributive type shock. And this is maybe a slightly extreme example of the kind of hyperacute patients that we transfer, but those my main experience of this is in South London, more recently over the last 4 years working at King's. But this is not too different from some of the patients that Sprint have brought to us over the last couple of years. So these patients do present a challenge. And what I was going to go through is some of the aspects of managing that kind of patient, and hopefully answer some of the questions that you have about what's the right thing to do at the right time. But clearly someone like that is very sick. You know, I think, you know, in the past, if you go back 5-10 years, I think we would have said maybe that person is too sick to transfer, and maybe that person's never going to get to a liver transplant, and they should just have supportive care locally. But in general, as with everything else in medicine, we're much more proactive and aggressive, and we would almost always want to try and transfer that patient for either for an assessment to think about whether they might be suitable for transplantation if they meet criteria, and certainly to think about Plex as a bridge to recovery. So there are more things that we would like to offer that patient, which means usually they need to move to a liver centre. And so I guess in London, the complexity of the liver transfer is that you're moving somebody who is quite sick, and I guess having spent a little bit of time with the Sprint service, this kind of patient on the left is the kind of liver patient who's on multiple infusions, in probably quite significant vasoplegic shock, on a ventilator, and comes with a bit more baggage than a lot of the transfers that we undertake. And you're going to be moving them either to, I guess, Leafy Hampstead up here in the top right. This is the Royal Freeze Liver Critical Care Unit on 4 South, or to King's. So this is still semi-leafy Camberwell. We have a little bit of a park behind the hospital, and this is our liver ITU. So you're going to be probably moving to one of those two places. And I guess one of the things that has really changed significantly from my perspective over the last couple of years in our region with the advent of Sprint is the coordination of all of this, because prior to Sprint and all the transfer services being available to us, it would be a case of me and a consultant in a referring hospital trying to decide if this patient was stable enough for them to send their senior SHO, you know, if you're lucky, a more senior registrar, you know, an hour and a half, 2 hours up to King's from, you know, lots of our referrals come from on the south coast, Kent. So it's a much more challenging situation. I think the transfer services that are available now have completely changed the way that these transfers are managed. And it's not uncommon now, actually, that the comment for us is that the patients arrive in a better condition than when they left their referring hospital, which is completely different to how this situation existed a couple of years ago. But I think one of the main things that's really made this process effective is the coordination, and there is now a team who's responsible for coordinating all of this. You know, the 80% of the patients that come to us have a pretty straightforward transfer, and it doesn't involve a huge amount of liaison, but there is always good communication about timing, etc. But there are some complicated patients, like the young lady we just talked about, and those are the patients where it's really beneficial to have like a WhatsApp group, a Teams meeting beforehand, and some really kind of good coordination between the referring and receiving teams, and with the transfer team. So I think that's one thing that really should be applauded and should continue. I did speak to one of the consultants at the Royal Free last night, and they don't have I couldn't get a direct numbers for you for Force South, but I think what he did say was it's just really important to find out who the consultant is that you're referring to, which you would already know, I guess, and for that person to be involved in the discussion in the same way. So I've just got a couple of slides about acute liver failure, just to kind of set the scene and the physiology, and then a bit more discussion. You remember acute liver failure is this liver disease without any pre-existing cirrhosis, usually say up to 28 weeks duration. If they have a coagulopathy with their liver injury, which are usually defined as an INR more than 1.5, then we say they have an acute liver injury. If they develop encephalopathy, then we define them as having acute liver failure. And you remember that there's these three sort of distinct phenotypes. The hyperacute, which is where the liver injury to the encephalopathy time is between 0 and 7 days. The acute liver failure is where it's between 1 and 4 weeks, and then the subacute phenotypes. The subacutes tend to come over much more electively. They're kind of slowly deteriorating on the ward, and usually kind of ward to ward transfer. The acutes sometimes can be a bit more interesting, but really from an acute liver failure perspective, it's the hyperacutes that represent much more of a challenge. And the reason is that they're the ones who develop more significant multi-organ failure. So you'll remember that the hyperacute phenotypes tend to have a much more profound coagulopathy. We can talk a bit more about how that impacts things and how we monitor that. They tend to be much less jaundiced, so it's not unusual for them to have relatively normal bilirubin, but they're much higher risk of intracerebral hypertension. Previously, so this is kind of looking at data going back really since the 70s, when King started collecting data on acute liver failure. Previously, the prognosis was not good for any of these groups. Our modern critical care management and the advent of transplantation has really changed that. We'd expect at least 2/3 of these patients to survive, and actually a lot of them survive without transplantation. So there's a real benefit in these patients from being in a tertiary centre, and so you know the reasons for transferring them, I think, in terms of their improving chances of survival are fairly clear. It's not a very common condition for us, although it's an interesting condition to treat. The numbers of patients that we have with acute liver failure have been fairly stable over the last sort of 15-20 years, and it's about 80 patients a year that we transfer in. It's not huge numbers in the terms of the context of liver disease overall, because you know ICNOC data suggests that about 5% of patients on critical care units have cirrhosis, so it's much more common for us to be accepting somebody who's got decompensated cirrhosis or a variceal bleed. But it's the acute liver failures that tend to be a bit sicker, and so they present a bit more of a transfer challenge. just to show you for your interest, on to the next slide, this one. This is the percent of patients with acute liver failure who come to King's who are transplanted, and I suggested that outcomes are improving, and alongside that the use of transplantation for acute liver failure at King's has been declining. So we're much better at managing these patients without transplantation, and that's because you know, their care is much better from the very beginning. So there's a lot of benefit to the patients in getting the early phases of resuscitation right and getting the transfer right. You know, the management of acute liver failure is kind of in 4 sort of phases. The most important message really is early referral to specialist centres, which we try and encourage from all of our referring centres. The 4 phases I would say is, one is resuscitation and supportive care for organ failure. Initiate any cause-specific interventions, so that's usually NAC. About 50% of our hyperacutes are polypharmacy or paracetamol intoxication, but there are other specific interventions like for viral hepatitis, etc. So that will already have been thought about by the referring and receiving centre. To define a poor prognostic group, which is where we would try and identify those patients who are not going to get better with standard medical management and who might require liver transplantation, and then to anticipate and prevent complications, and that's mostly thinking about optimal organ support and preventing infections, etc. So those are the phases. I think the reason we would really advocate earlier referral is because the trajectory of these patients is not always completely clear. And so here's another example, a 22-year-old man who is day 3 in his local hospital with a hyperacute liver failure, again from a paracetamol intoxication. He's got an AST of 8,500, which is high. He's got a bilirubin of 38. He's got an INR of 3.4. His renal function is normal. His creatinine is 85, which you may argue may be a little bit high for a 22-year-old. His lactate is 2.9. pH is just about normal. He's passing some urine. He's alert with a GCS of 15. So he meets some criteria which we would be slightly concerned about. But apart from the lactate, which may be a bit of under resuscitation, he's essentially got an isolated coagulopathy. So he's not really got established kidney injury, he's not got any encephalopathy, he's not particularly acidotic. He's someone I would be concerned about, but I may not decide to bring him over today. I might watch his blood tests over the next 24-48 hours to see which way things evolve, because he's got a reasonable chance of escaping hospital. And there is a man escaping hospital still in his hospital gown, but he has got a chance of progressing to acute liver failure requiring transplantation. So he's somebody who I would be in regular contact with a referring hospital about, and ideally if things were going in the wrong direction, I'd want to transfer him before he deteriorated further. So you should be able to make a decision about someone like that in the next 24-48 hours. These are some fairly old criteria which are kind of triggers for us for transfer, and we haven't really had any new data which updates this, but the kind of patients that we would almost always bring over will be someone who's got a significant coagulopathy. We get a lot of referrals for paracetamol intoxication, and so we see a lot of sets of blood tests where the AST is very high, the ALT is very high, they have an INR of 3 or 4, but everything else is very reassuring, and you sort of feel that things are going to settle. And so we may not always bring over somebody who's got an isolated coagulopathy, but any degree of encephalopathy, persistent hyperlactatemia after resuscitation, a persistent acidemia, significant AKI, those things are much more concerning of a more significant liver injury, and we're more likely to transfer that patient. In the sort of the subacutes, which I said are less relevant to you guys probably, more significant jaundice and reducing volume, but it's the hyperacutes that we're really talking about today. So prior to transfer, so if we say that we are going to accept this patient, let's talk about the sort of 17-year-old who was on the first slide. We will have given some advice about airway management, cardiovascular support, neuroprotection. We'll have usually advised if they're encephalopathic to start some antimicrobials, and we'll have made a decision about whether or not it's beneficial to start some renal replacement locally. So you may turn up to a patient who's already intubated and on quite a bit of cardiovascular support and who's on a filter, and so we need to plan the context of all of that. I thought I'd pick out a few specific topics from which are directly related to sort of transfer medicine, and then open up for discussion. So I guess the first thing that we think about in that sort of algorithm of management is airway protection and when to intubate, which is always quite a difficult topic in the context of transfer, because there's always this dilemma of they look okay at the moment, but they are at risk of deteriorating, and what is that risk, and how can we avoid having to intervene en route? So there's lots of factors that play into this. I think when to intubate is a little bit easier, I guess. We know, those of you who've seen lots of patients with acute liver failure will know that the encephalopathy can be quite rapidly progressive, and over a period of hours someone can deteriorate from being a bit drowsy to aspirating. So in general, we have a relatively easy decision to make when somebody is sort of grade 2 encephalopathy, which is where they're a bit confused with a flap and becoming a bit drowsy. It's relatively easy to say that we should intubate those patients because they're likely to be heading in the trajectory of needing to be intubated anyway. So it makes sense to do it before you transfer them and just eliminate that risk. I think that the patients who have a milder encephalopathy are a little bit trickier, because we've all seen patients with hepatic encephalopathy. Often they can have a best GCS of 15, so I don't think the GCS is particularly helpful in your decision making, because they'll be a bit drowsy or a bit confused, but you can wake them up and you can get a good GCS. But I think the decision making then is sort of flips into, what are the risks of not intubating this patient, and I think that's when that discussion is between the referring and the receiving teams is really helpful, and everybody has their own slightly different opinion on this, but clearly the factors that come into it would be what's the trajectory of the patient, how rapidly are they deteriorating, what are we expecting to happen over the next 5-6 hours, and how long is the transfer. And for us, transfers vary from quite local, so St Thomas's is 15 minutes away, versus Northern Ireland, when decision making might be quite different. So I think that's something which should be discussed between the receiving and the referring teams. And the other thing that often comes into it, particularly evenings, weekends, night time, is the skill mix of people around to perform the transfer. And that's again where transfer services have really kind of revolutionized things, because it wasn't in the past, it wasn't uncommon for somebody not to get intubated, just because if they did get intubated, then a consultant would have to come in and cover the hospital while an SHO went on the transfer. And I think that sort of influence on decision making has changed quite a bit, but clearly it still is part of the discussion sometimes. So I think you just need to have a sensible discussion, and I think we are quite sensible about it. I think if you have a conversation with one of the consultants on liver ITU, we will help you try and manage the patient in the safest way we can, and we're quite cognizant of all the challenges that this brings. I'll just got a couple more slides, and then we can open up for discussion. So cardiovascular support, I think you can spend a long time talking about, but essentially they have quite a profound progressive vasoplegic state. I thought I was going to pull up a few examples of fluid balance charts of our patients when they arrive, and I pulled up the most recent one, who's on the unit at the moment, and I realized I didn't need too many more to make my point, because the point I was going to make is that they often need a lot of fluid, and the one of the difficult groups of patients that we that are challenging for you and us are the patients who've been under resuscitated on a medical ward, perhaps. So you take a young person with a paracetamol intoxication, they've been in hospital for a couple of days, they've had their NAC, but they haven't had much more fluids because they've been drinking, and everybody's been just encouraging them to drink. But actually they can become quite fluid deplete quite quickly. And that's the patient who you'll be called to see in a bit of an extremist, because they're very under resuscitated, and they've got a lactate of 15 and they've got a pH of 7.2, and you're just going to be constantly playing catch up. This is a very common, almost universal trend, is that in the first couple of days we just pour some fluids in. So you can see this patient was 12 litres positive in the first 24 hours, and they just needed a huge amount of volume resuscitation. And I think if there's one sort of message about cardiovascular support, it's that you just need to continue to fill these patients, and you will see the trend of vasopressors usually decline as you get the volume resuscitation right, but they do need a lot of volume. And you use whichever cardiovascular monitoring you prefer to use. There's no particular catch outs in acute liver failure, except it's a very profound vasoplegic shock. There's some pretty historical data that these patients have a relative corticosteroid insufficiency. We have a low threshold for starting some steroids, some hydrocortisone, if they're on significant doses of vasopressors, and probably a bit of a lower threshold than you would normally for septic shock, but that's the only real difference, I think. But you can ask me questions about that. From a sort of are people diving in, or am I carrying on? I can't see any.
Carry on.
I'll carry on. In terms of metabolic support, I think this is a sort of more of a challenge for transfer, and I pulled up. This is a similar patient whose arrival blood gas showed a pH of 7.21, basic S was -7. The potassium's 5.9. They hadn't been on a filter before they were transferred. Lactate was 3.2, which wasn't too bad. So quite often this sort of sick hyperacute liver failure patient, you'll pick up on the ward, and they'll be in a bit sicker than that. The pH might be a bit lower, the basic S might be a bit lower, the lactate might be a bit higher, and you've got to make this decision about whether or not you need to bring them to your intensive care unit, give them a spin on a filter to make them stable enough to transfer, or whether or not that you can transfer them without doing that, whether you can support them with some bicarbonate, some potassium management, whether or not it's going to get better with some better volume resuscitation. I think those decisions are quite challenging, and they're quite individual. And what we try and avoid, obviously, is somebody arriving in a worse state than they're leaving in, because there is a point at which the acidemia becomes a bit of a vicious circle, and then you're unlikely to be able to salvage the patient. So I think that's where this real sort of coordinating discussion is really important, because maybe better to stay and play for a few hours, get some volume in, spend 6 hours on a filter, and then transfer them, rather than transferring somebody who might arrest on the way or as they arrive. And we can all think of examples of that. or certainly I can in the last sort of 4 years. So I think the metabolic decisions are a little bit more difficult, but those are the ones that we were quite keen to discuss at the time. I just wanted to make a couple of points about neurological support, because I think that's an important concept that people focus on. You know, I think the differences between acute liver failure and any other cause of potential raised intracerebral pressure is really, it's kind of a hyperemic cerebral edema or hyperemic raised intracranial pressure, mostly driven by both ammonia and an inflammatory response. So ammonia, to cut a long story short, causes astrocyte swelling, and the degree of intracranial pressure is closely correlated with the level of arterial ammonia. This is in acute liver failure, and so those go on in a couple more slides to explain a bit more detail, but those patients with a higher ammonia are at more risk of raised intracranial pressure. And those patients who are more shocked and more vasoplegic and have more cytokine release are also at risk. And so if we look at all of our cohort of patients who are transferred to us with acute liver failure, the ones who have raised intracranial pressure tend to be younger patients, so median age of 30 in this group. The female patients have a higher proportion, and those with paracetamol intoxication, so it's a hyperacute group. Those are the more profound coagulopathy, so higher INR, I should say. Those with renal failure, those are the lower sodium. So not surprisingly, the patients who are a bit sicker and a bit younger, because they've got a little bit less space to swell, are more risk of raised intracranial pressure. And most of the clinical signs of that are quite late. So you can get extension posturing and clonus and pupillary changes with encephalopathy, but they're very late signs. So really our focus has been to prophylax against this, and that's the thing that's made the biggest difference. The main method of ammonia clearance is renal replacement therapy, and the rate of ammonia is very easily cleared with hemofiltration, and the ammonia clearance is directly related to the dose of your ultrafiltration rate. So this is why sometimes when we're monitoring the ammonia in the unit and it's not clearing on sort of standard filter rates, we go a bit higher. And so not uncommon for us to recommend starting at higher exchange rates than you may be more familiar with in sort of non-hyperacute liver failure patients. There's some pretty good data about a survival benefit in prophylactically getting the sodium up in the range of 145 to 155. So we always start our patients on a sodium infusion when they arrive, but if you see a patient who you're transferring who has a sodium below that range, then it's worth thinking about whether it's worth doing something to get that up. This is our sort of little package, and I'll go through the right side in a bit more detail on the next slide. But we focus really on preventing raised intracranial pressure, so that's prophylaxing with standard sort of neuroprotective strategies, osmotherapy and ammonia clearance. And you know, I've taken out all of my kind of acute liver failure slides, but that's transformed the mode of death in acute liver failure, where previously more than half the patients died from intracerebral hypertension. Now it's very rare. I said that all the clinical signs are quite late. We tend to monitor quite aggressively with TCDs and regular imaging. We don't use a lot of ICP monitors these days. And to go through the second hand, the sort of neuroprotective strategies are pretty closely correlated to your standard targets with TBI. We're perhaps a bit more aggressive earlier on with osmotherapy, and we start prophylaxing to get the sodium up quite early, and we want to get the ammonia down towards the 100, less than 100 range as early as possible. We don't prophylactically give anti-epileptics. We use these sort of rescue or second or third line measures like bolus osmotherapy and hypothermia, thiopentin, if there's kind of clinical concern, and maybe some risk if you take that 17-year-old that her pupils might change en route. So you'd always want to be prepared that you take some bolus osmotherapy or some thiopentin with you if you're transferring someone with an acute liver failure. And I think we're less concerned about the risks of hyperventilation in this group because we said it's a hyperemic phenomenon. Actually, there's some pretty old data that shows that actually your cerebral blood flow, your ICP can come down a little bit with a reduction in your cerebral blood flow in acute liver failure. So we're less worried about prolonged periods of hyperventilation. So if you needed to use that for your transfer, then I think that would be reasonable. I have sort of paused there because I kind of have sort of gone through the main aspects of the transfer that I guess may induce some questions, and I thought I would stop and just see what people thought and see if people had specific cases or things they wanted to talk about. And I've got a few slides on coagulation which people might want to discuss if they want, if there's time.
Thank you, Brian. That's amazing. We've had a couple of questions come through. So James has asked, which fluid is your resuscitation fluid of choice and what you'll be running on transfer, understanding it may be case dependent. And that sort of reminds me of the Intensive Care Society's quite recent publication of 10 myths about albumin. So I was wondering if you could speak about that a little bit.
Yeah, absolutely. So let me just unshare so I can see everyone. So so I think we have gone through various cycles of our most preferred volume resuscitation fluid. At the moment, we've just made a switch back to Hartmann's from Plasmolite. So I think just a balanced crystalloid is what we would always reach for. I don't think it's unreasonable to use 0.9% saline in this group, particularly if the sodium's a bit low. But a balanced crystalloid is what we would usually use as first line with a background infusion of hypertonic saline for the sodium. I mean, we in the same way that we would sometimes use some HAS in patients with septic shock, we sometimes use HAS in patients with acute liver failure, but it's a very different group to the patients with chronic liver disease, and you wouldn't be reaching for albumin at all in the kind of early phases of resuscitation, I would say.
That's great.
That
Thank
answers
you.
your question.
It does. And then Nick's asked for longer transfers. Say, for example, we've been to Wales, and I know you guys do some work down in Kent. A patient with significant metabolic challenges, refractory hyperkalemia or frequent hypoglycemia, etc. Do you guys in Sprint use an ISTAT or equivalent sort of EPOC or something like that?
So look, I think makes complete sense. I've been out of Sprint for a few months, so when I was last in Sprint, there were certainly had some machines which were about to become online. They probably are available now. I would have thought someone else will be able to answer that question. But the things that concern you would be the potassium, I guess, most of all, because I guess you're starting off with a patient who's got a high lactate, who's got an acidemia, and your plan is going to be to continue to resuscitate them en route, which is mostly going to be volume and titrated vasopressors. I think it would be nice to be able to see the pH, the lactate, but en route, unless you stop and plug them into a filter, there's not a lot you're going to be able to do. You know, we would probably have a discussion about whether or not somebody should have a background infusion of bicarbonate, and I think we'd have a low threshold for that. And so if I was transferring that patient with that set of blood gases that I showed you, I would be giving them a bicarbonate infusion in the background. And that's part of that kind of conversation that you have before the transfer, I think. And I think the benefit of the ISTAT would be that you'd be able to rescue the acidemia if it deteriorated en route. But I think with good fluid resuscitation and some bicarbonate, then you probably would be able to get them through that transfer. The main question is whether or not you're going to have to treat a high potassium, I guess, as well. So those things are the kind of challenging metabolic aspects, I guess. Yeah. Chris has got a question.
Yeah, Chris, go for it.
Yeah, thanks, Brian. I've got a couple of questions actually. One is the ventilation in hepatopulmonary syndrome, i.e. shunting. Are there any top tips in terms of for transfer, whether we can do anything about that or anything we can add to optimize gas exchange? And the second is just a general question about referrals along specialist pathways. So Nectar will have the Royal Free and acute liver thing. We Sprint have obviously you guys. And do you think there's benefit in long-term retrievals from the local provider of critical care transfers? My own bias is yes, through contacts and familiarity with people and a developing expertise. But how do you feel about that?
So I guess the first question around ventilation is important, but I think so you do meet different phenotypes of these patients, and certainly we do see hepatopulmonary syndrome or some evidence of shunting in the acute liver failure group. It's not very common, but we do see it. And I guess the things that we would try is the things that you would try is to titrate the PEEP to get your optimal oxygenation, but also to try the positioning, because that patient, if you really think they've got shunting, then they're probably best flat than sitting up in HPS, that sort of orthodeoxia component. But most of the patients who you'll transfer like this have a pretty clear chest, and that's probably that's one of the reasons that you can kind of more safely say that they will benefit from aggressive volume resuscitation, not usually balancing that really leaky sort of non-cardiogenic pulmonary edema. Occasionally you meet someone who's got a bit more of an acute lung injury, and that can be a bit more challenging. I think traditionally, we did worry a lot about using higher PEEPs in patients with an acute liver injury because of the risk of making the liver more congested. I think you balance that against getting adequate oxygenation, and I think we do tend to favour a slightly higher PEEP strategy in these patients when they start to develop an oxygen requirement. That's probably not going to be relevant in their kind of early transfer setting. That's probably a little bit later on in their journey, but it's something to kind of balance and think about, I guess. But there's no, I think, what we would usually advise is that you do the right thing for the patient at the time. So if you think that they, from a respiratory perspective, would benefit some more PEEP, then I wouldn't let that stopping you I wouldn't let the liver failure stop you doing that. And your second question, I think, is really important. I think liver medicine in general is still in this sort of very sort of archaic phase where the networks are not established, and like they are for trauma and respiratory failure and all the other things that we meet day to day, and all of the referral pathways are based on traditional relationships, and there is a huge financial implication in switching away from that, because all these transplant centres have spent many years building up their referral networks because the money comes with transplantation. So you will find that you're being asked to transfer somebody from Scotland to the Kings, bypassing 3 other liver transplant centres on the way because of traditional referral routes. Now, I think you could make quite a strong argument to say that may not be the best thing for a patient, because if there's a liver transplant centre in Newcastle and Leeds, why don't they go there? But that's something that that I think liver is sort of struggling with and hasn't yet managed. I think there is a huge benefit in these group of patients, particularly the acute liver failure group of patients, in being in a tertiary centre. You know, there are I think just the overall access to the wider multidisciplinary aspect of managing these patients is more than just because you can make a good argument and say, well, look, they're in a really good hospital, they've got a great critical care unit in this particular hospital, I know they're going to get really well looked after, they're not going to be a candidate for transplantation for this and this reason, why don't we leave them locally to manage that? And maybe they could even have access to Plex and the kind of things that we might do at King's. But I think the management of these patients is much wider than just being on a good intensive care unit, and I think there's some great benefit in bringing them, because each patient is slightly different and there's nuances to it. But that's my personal perspective. But I think the thing that I would work on if I was had any influence with NHSE on this would be about the networks, because I think that's clearly the thing that would make most difference and be more sensible to address.
Thanks, Brian.
Thanks, Brian. That's really good. We've got one more question from Nicola, who says, would you expect to see worsening encephalopathy in under-resuscitated patients with mild neurological deterioration once you start pouring the fluid in? Bearing in mind it's obviously quite patient-specific.
Yeah, it's a really good question, but it's really common. So yes, so the kind of patient that a common referral would be somebody who's got that sort of significant paracetamol induced acute liver injury, and they're referred because they're a bit encephalopathic. So they've got an INR of 3 and they've got an AST of 5,000, but they're not in renal failure. Their lactate's normal, pH is normal, but they're encephalopathic. It doesn't quite all fit together, because you'd expect maybe more of a significant metabolic disturbance before they become encephalopathic. Not always, but you may do. And so that's the group that we would have a kind of discussion about, because that patient may respond to just volume replacement, and that you might find that some of their encephalopathy is because they're under resuscitated. They may have had some alcohol with their paracetamol, they may have had some codeine or some other drugs, opiates, and so we would want to have a discussion about that sort of patient. We sometimes end up advising to intubate that patient because it's the safest thing to do, but it's quite nice to see if you can optimize the resuscitation first, because you sometimes find in that group that they can avoid the acute liver failure pathway. Yeah.
Thank you. One of the themes coming through here is clearly the importance of coordination and communication, and linked to that is what will eventually hopefully become networks similar to, as you mentioned, trauma and respiratory failure. Yeah. On that theme, have you got a sort of got a liver transfer SOP? So I think we talked about this quite a lot, and Pete may be able to update you or Chris with a bit more recent discussion. I think this is one of those things which is a little bit tricky to put into a guideline. We certainly have some guidelines on the management of acute liver failure patients, which I can happily share with people. They're not controversial, but the actual transfers are relatively individualized, I would say, but which is why we haven't sort of tried to compact everything into an SOP, but we could sort of maybe, if people think it would be helpful, we could maybe do an extraction of the acute liver failure management sort of guidelines into a sort of the things that are relevant for transfer, the things to think about, more of a kind of checklist of how I thought about this. I think particularly around the metabolic things, because it's probably easy to leave without taking some bicarb or some thio and some sodium and things if you haven't sort of got it on a checklist. I don't know what you think, Chris.
Yeah, I mean, I definitely think we should develop some sort of checklist for liver transfers in terms of the availability of things such as iStat and thiopentone and things, and the appropriate fluids, etc. I believe this is a specialist transfer, just because of familiarity, and also, as John said, communication links with a specialist centre, and I think this is just like in ECMO or severe respiratory failure, or indeed probably emerging in cardiogenic shock. Familiarity is good for patients. I think what our approach in Sprint is going to be to develop an educational package for competencies for our staff, and as staff become more permanent, perhaps it becomes part of a more substantive, it becomes part of their job, there'll be a series of competencies and a little bit of training that they'll have to go through, rather than developing a sort of definitive SOP. So that's what I think we'll do, and liver is something we've talked about, and there are other areas like HSID, which has come up recently, that people working within critical care transfer services just need to have those competencies, and I would say liver deserves that. And I'm sure there are others, and they're very happy. This is a place to discuss specialist areas for dedicated training, and of course, Nectar and Sprint and whoever else can share these, and it can be a pan-London endeavour.
And I think just to add, I think I cannot emphasise enough how much Sprint for us has revolutionised the management of these patients, because this is a specialist transfer, and these patients are sick and relatively complicated, and I'm quite young, but I can still remember the first 2 years of my career where these patients will be transferred by a relatively junior reg or an SHO who didn't really understand the intricacies of all the things that we've just talked about, and not because they not through any fault of their own, just because they've been put in a position that they probably shouldn't have been. So this is where these are, and I wasn't joking when I said at the beginning that it's not uncommon now for these patients to turn up in a better state than when they left after a 2 or 3 hour transfer, and that's because they're getting ongoing critical care resuscitation while they're being transferred, and it's completely changed the way that we can think about what we can offer for these patients.
Can I just
thank you to everybody.
Can I add one more thing? We have, in Sprint, we do have an RRV on occasions, and the reason that one of the benefits of the RRV is that we can send and we have done this, is send the RRV to pick up a King specialist liver nurse and meet us at the referring hospital, and that adds an enormous skill set into the mix for the patient in the back of the ambulance.
Thanks. There's clearly appetite for some sort of checklist or shared learning, both from us in Nectar, and it sounds like you guys as well. And we'd love to do the usual Nectar thing of plagiarizing other people's SOPs. So we'll happily get in touch. We are out of time, unfortunately, so I'm going to hand back to Anna to introduce our next speaker. But first, a big thank you to Brian. That's an excellent talk. Thanks so much. Anna, over to you.
Thank you very much indeed, Brian. That was really, really interesting. So the next speaker is Kieran, who's very kindly going to present our